So we're going to talk this morning to kick this off until the first break about the future of healthcare, our prognostic related to revenue and the critical revenue implications. So there's a handout. Take notes, listen, disagree, bring up questions later on, discuss it with your crowd at your table. But we're going to talk about the ability to tie the future of healthcare to the revenue issue, not just the quality issue and the service issue and the technology issue, but to the revenue implications. So I want to go through this with you and see if we can make a difference in how you think about what's going to happen in the future, because we suggest what's going on in the future is already going on right now. And it has nothing to do with Obamacare, whether you like it or don't like it, hope it goes away or morphs into a different jello. It has to do with the fact that CMS has been plotting a long time what to do with revenue at all levels. Hospitals, critical access hospitals, home care agencies, PACE programs, special need programs, Medicare, Medicaid, nursing homes, any kind of post-acute environment. And so this is going on through several different administrations over a period of time. And so we believe that the future is tied to not politicians. It's not tied to the current economic issues we're involved in, the gridlock in the Congress over debt reduction. We believe it's tied to a single set of stuff that has got permeated in the belief systems of the major payer sources. And what Medicare and Medicaid does out of CMS, managed care follows. That's just a done deal. So having said that, we think there's hope if you get on board with the future now. And you guys tend to be early adapters and trendsetters, working with us and some innovations that you're doing yourself, and we know that up front. You're not laggers, you're trying to be trendsetters and get ahead of the game. Here's the changes that are going to happen. We're going to a horizontal system versus a vertical system. So any of you that want to live in a vertical system, that we can go deep this way, you're toast. Man, we're just going to really fill them beds. There's an insanity. Since the government's plan is to not have near all the beds full, and any state, and with the feds, and they don't want them all full. Which is why the number's been going down every year for the last 10 or 15 years, and the occupancy rates are in the mid-80s out there in most states. So filling beds is a vertical system. So if that's what you're going to do, it ain't going to work out. Saying we can do it alone, we can be a self-contained entity in Greater Tennessee, and we don't need partners, you're smoking something. You have to play in a horizontal, across-the-board continuum, not in a vertical system. Hospitals are the worst at getting that. And now the feds are doing anything they can to punish the hospitals not to be vertical systems. They want them horizontal. They want you taking care of the money follows the patient, the medical home model. They want the hospitals stopping readmissions. They want to deal with the issues associated with partnerships out there. So the feds, in a plan over a long period of time, want a horizontal system. They're tired, and let me just tell you about a money thing. The feds, particularly, and if you don't think the feds control something, then you're nuts. Quit worrying about your state. The feds control everything. They just decide what to leave alone. They would federalize Medicaid tomorrow if they could. They just can't get away with it for pork barrel and getting congressmen and senators to vote and giving governors the illusion that they control Medicaid money. But they don't control Medicaid money. 58% of it on average in the nation comes from the feds. More than that, by the time you pay your interesting provider taxes and all that other Rube Goldberg kind of process, it's close to 65% of the money comes from the federal government. And the feds would love to federalize it if they could, because they're tired of listening to stories about $120 a day down in Texas, and that would be a good day in Texas for Medicaid. $120 a day. New York State, New York City, $270, $280 a day, and they still can't make it float because of the things they're required to do for it. You know, so I mean, how's that system working? So the feds, and there's 50 different eligibility requirements to get into 50 state programs. Got 50 different eligibility requirements to get into Medicaid, and the feds are tired of it. And worse that, they're tired of having a reimbursement system for nursing homes and a reimbursement system for home care and a reimbursement system for hospitals and a reimbursement system for adult daycare and a reimbursement system. They don't want it. What they want is to take a half-eaten zebra, throw it over the zoo fence, and let a pack of hyenas run after it. You all being the pack of hyenas. The half-eaten zebra means you're never going to get a full, nice zebra to eat, which is all the money you'd like. So, let me give you examples of horizontal systems, payment systems, Medicare. Medicare is a horizontal system. It's evident when they started with PPS, please pay something, which is how some of you bill. Here's a cigar box, please just give us some. But when they went from fee-for-service to capitation, under RUGS categories, 60-some, probably 70-some in 2 years. But, it's evident that they want the money to follow the patient, which is a horizontal system, not a vertical system. So they want Medicare to be a system where you don't stay in the hospital for $2,500, you go to a nursing home for $500 or $600, you don't stay there very long, you go to home care, and so the feds don't want them in expensive places. They want you to set up partnerships. That's why they're experimenting with ACOs and bundling and all that stuff, and there'll be 1,000 ACOs by 2016. There'll be 1,000 of them. And by the way, there'll be another 500 that are morphed versions of their own ACOs that are not even government ACOs, like Mayo. They run their own ACO now. Why would they play in the government-sponsored ACO? They got their own. They control the doctors, which is the whole secret to the messiness of healthcare, controlling doctors, herding cats. And so that's why every big hospital system is buying up doctors, so they can supposedly control them. So, Medicaid is a horizontal system. They want you to play across continuums. They want you to figure out how to handle the dual eligible. They want you to figure out how to not put them in nursing homes if you don't need to. 7 of your states in this room right now have medical necessity evaluations, and more are coming right now to take light care Medicaid out of nursing homes. Be able to handle dual eligible people, because the feds are going to blend those monies. The feds, now they would love it to be a federal program for dual eligible people, whether they're PACE programs or institutional SNP programs or other kind of capitation at-risk programs. But what that basically comes down to is when you move to managed care, the next thing, you might have to be a seller of services and a buyer. A buyer and a seller. Not just a seller, because if you're a seller only, you take the price on the open market. If you're a buyer, you can control the price you set to pay yourself, which means setting up by default your own version of an insurance company. Private pay doesn't exist. It doesn't exist, and most of you, if you have any private pay, it basically covers the loss you sustain on Medicaid. So, and then bundling's going to happen. Value-based purchasing is absolutely going to happen. You will hear later on in another eloquent presentation after lunch about value-based purchasing, so I don't want to take that thunder, but you're going to have to be measuring core measures in customer satisfaction on a horizontal comparative system with every other competitor out there, just like the hospitals are doing right now on HCAHPS and quality indicators and readmissions to hospitals and all that. So the nursing homes are going to do it too. Because if they can make the hospitals do it, you all are easy targets. It's real easy to roll that data up for nursing homes, and it won't be that tough if you can decide to have partnerships that help you. So I need you to ask your neighbors, before I move to the others, well, I'll just move to the others real quick, customer preferences. The customers don't want vertical systems. I don't want to jump from this home care agency to see if I'm eligible for this nursing home, to see if I'm eligible for adult daycare, to see if I'm eligible to, can I get into the hospital or no? No, I'm not an enrollee in their program, so they're going to try to divert me. The customers want a horizontal system. I mean, they do. They can't figure it out now. The average senior can't figure out Part D pharmacy benefits, let alone how to jump through the hoops of 7 or 8 different qualification systems to get in. If you look at partnerships, you're going to have to do them. Yes, you're going to have to partner. Assisted livings with nursing homes with home care agencies with nursing homes. You're going to have to partner with the hospitals. You're going to have to make decisions which partnerships to do. And it's kind of like forming giant conferences for football, which is what all of us men are talking about now. Will Texas A&M go south? So my example, a sports theme, if you say, well, we're in the middle of nowhere, Clint, we're in rural so-and-so, you're going to have to find partnerships too. I'm sorry, because if you heard my analogy a while ago, if Texas A&M or Texas split off from the Big 12, Baylor, Kansas, Kansas State, and all the small schools will still have to find partnerships to exist. They'll still have to get a conference. And I'm telling you that I don't care if you live you got a town of 1,500 people out there and you think you're in the middle of nowhere, you're going to have partnerships. You're going to, whether it's with the physicians, whether the hospital, whether it's the assisted living down the road. See, the average nursing home we work with still looks at them as enemies. They're the partners. They're partners. Now, not every one of them. I don't need 38 assisted living partners. I need one who has people who go in the hospital for 3 midnight stays and needs recovery in our building, and then we send them recovered people who need to go home, but not to their original home, to a new home because they're not safe in their original home, and they need to go to an assisted living. I just want you to get the idea that you're not going to be able to live it alone. So you companies in the room with 10 buildings, 20 buildings, 30 buildings, 50 buildings, whatever, you can't do it by yourself. You can't. You have to partner. And you better do it rapidly because you could get left out and somebody form a new mega conference without you in it. That's the way that, now you can set up your own niche business that no one else has if you're willing to take risk, and you'll hear about this today. If you want to go after capitation risk programs and become a buyer and seller only in your marketplace, man, you've got something no one else got. If you want to run Huntington's Chorea in a 100-bed building and no one else can do it, you can have an international Huntington's Chorea business if you'd like that. If you want to be a pulmonary business for pediatric children, if you would like to do an AIDS business, if you'd like to do a methadone treatment, I mean, if you want to do specialty businesses, they're out there. But if you want to run general skilled nursing, you better have dates. You better have dates. And by the way, with the feds are going to give you a date you don't want, which is managed care, because the feds do not want to pay the bill. They want somebody else to pay the bill. So they're going to incentivize managed care like never before to become your new partner. Even in towns where there's no managed care right now, there will be. If we are a horizontal system in the future and the government is not our friend or our enemy, they're simply a purchaser of services either through themselves or somebody else, then you distinguish yourself by doing the right thing. I've given you the 8 pillars for the right thing. It would seem that we could sum them up in a series of products to show that we're different and that we have the outcomes to prove that we are different. That's the future of healthcare. That doesn't sound so dismal to me. It sounds like work, but it sounds to me like there's hope if you have a series of products, you have outcomes, you have services that are clustered into products, you have processes that are proven and worked on to generate the outcomes, and then you have the 8 pillars in place, or you're constantly working on the 8 pillars. Looks to me like you have self-destiny. You have the chance to control something rather than payer sources and regulators. That's our belief anyway, and I understand we're optimists. But I think that choice is ours as we move forward in the future.